like that the knowledge and expertise goes down to all hepatologists, gastroenterologists, and surgeons together. So we have an outstanding surgeon, we have an outstanding radiologist, and a very good clinician who are presenting this case. And we do hope that more people from all countries can join. With that, I would like to pass on to the moderator, Professor DJ Kim and Professor Wasim Jaffrey. Over to you, Dr. Kim. Professor Kim, you may kindly start. Unmute yourself.
Yes, because Wasim Jaffrey is not here yet. I will start the session of three eminent speakers. The first speaker is well-known Dr. Ashok Chaudhary, additional professor of hepatology and liver transplant at ILBS, is well-known and who coordinates APASL ACLF Research Consortium, ARC. He has a special interest in ACLF, artificial intelligence, and HCC. He also the course coordinator for the current RCAP. He will deliver a talk on case of advanced HCC approach. Professor Chaudhary, please. Are you ready to show your slide?
Unmute, please. Professor Chaudhary, unmute, please. You are muted, sir.
Okay, sorry. Hope at the outset, thanks moderator Professor Kim for a nice introduction and all my esteemed panels. I hope I'm audible now and the slides are visible. So we are going for a interesting case scenario. So this starts with a 31 boy who is having the index of having a SPP reactivation leading to SCLF around 12 years back. And he remained a regular follow-up, received news, and he got better and lost to follow-up in routine. Now comes to us with having symptoms of weight loss, decreased appetite, and has been suspected outside to have a liver as well and referred. So when I've gone through, he's found to having cirrhosis of liver SPP related. He's having portal hypertension and having large high-risk esophageal varices and compensated, have a large solitary SCC with portal vein tumor thrombus, however, FPO is normal. So how to proceed this in these patients? So when you've gone through these slides, as you know, this is the basic algorithm we taught across that our patient who is coming is child A, is having diffuse involvement with portal vein thrombosis and coming to the BCLC-C and is constituting advanced stage or BCLC-C. So what we have the options there. We have other option is SPRT because of having portal vein tumoral thrombus and followed by plus minus tests. We may have to consider simultaneous or sequential TKI or nivolumab because this patient was with us in 2017. That time there is no Atelli or Bevacid with the current first-line drugs available, and we are doubtful about whether this patient can be offered a transplant or not. So this is with this, we first consider this patient for the TAR, which is difficult because as per the CT I have highlighted, there is extensive arterioportal shunting. And you can see here, the portal vein is taking the contrast here. Hence, he was offered with a test only. So after the test, as a routine, we do follow up imaging after 1 month. You can see there is partial response and so how to go for. So in being a tumor of large size with and having partial response with first episode test. Here I just want to thought of whether we should have considered tear or the test. So this is just a comparison. If considered tear, this has less tumor embolization syndrome, better time to progress because this was better. However, in long term, equal overall survival, but it is costly. However, test is cost effective, require less expertise. D bits has now make up more relevant to be used in large lesions. We can go for multiple, and all the side effects like tumor embolization has been reduced by considering super selective methods. So we consider the second session of test after 1 month. And here you can see this is the whatever the liver lesions are there. He has gone second session. And this here you can see that glue has been embolized. This glue has been given just to close the atrioportal shunting, because we thought that this is because of this atrioportal shunting, the previous test was less effective. Hence, the glue has been injected so that the residual drugs, beads can be stayed back in the tumor area for a effective response. So I just will discuss, I think my subsequent esteemed panel will going to discuss in detail. So I want to know how many sessions of tests you can consider, what is the definition of test refractoriness, and what should be the gap between test sessions, because we have done here after 4 weeks, some suggest after 3 months. So this I need to know from my experts in the subsequent term. So after giving a test for 2 sessions, we gave it 3 months of period of just to see, wait and monitor. However, we have done for the triple phase PET CT. It shows that there is still the lesions are persisting. They are metabolically active. They are reduced, but this is still existent. So how to go for in this condition? So we have first session of test. He has received the second session, and sorafenib already started after the first session. So as per the MRECIST, this is a partial response, and if person test refractoriness is there or no, we need to see after the second session and 3 months follow-up. So it shows there is partly response. Hence, when we consider these patients, tear, as we have referred in view of shunting, test for TK already we have given, but there is disease has progressed. So we thought how to proceed. So we have left with another local regional therapy to control the disease is SBRT along with immunocheckpoint inhibitors. So this is an interesting study from China where found that the patient get cocktail of all the therapies to get a control. They receive sorafenib, they get immunocheckpoint inhibitors and SBRT in addition to TES sequentially, particularly when they have been having a portal vein tumoral thrombus. And they show that the response as far as the treatment, as far as the use of immunocheckpoint inhibitors are there, they shows a better survival, better progression-free survival, and overall survival. So when you consider the concept of TES, already we have considered whether TES plus SBRT has added advantages. So this is a meta-analysis of 25 trials that they have shown that these persons have a better survival, better disease-free survival, better progression-free survival. However, combination of therapy associated with more of gastrointestinal ulcer and little bit of deranged elect. Similarly, another also shows that the response is better when we combine SBRT plus TES, except the side effect, particularly leukopenia, in this meta-analysis of 10,900 patients. And as in our case, it is a large tumor radiotherapy, particularly SBRT has been shown in multiple tumor treatments. It has have a better overall complete response, partial response, stable disease, or progressive disease. So the study supports us to go for SBRT in this patient. So with this, we consider SBRT, particularly when it's medically inoperable, patients who are being considered for the bridging or downstaging, which will be discussed subsequently by our radiologist who is here. When there is TES or local therapy is denied due to vascular anatomy or tumor location, and if there is any residual or recurrence of the disease, and associated with PBT or as a part of palliative radiotherapy. With this, we need to select the patients who can be considered for the SBRT, who are not suitable for surgery or RFA have a better preserved liver function. At least 40% liver is uninvolved by the cancer, so that radiation liver disease will be minimum, and less than 3 liver tumors, particularly in the liver, and maximum diameter of the port should be considered area of 15 centimeters, and tumor should be more than 1 cm. So contraindications for SBRT is I'll see when enzymes on the higher side, when the tumor residual liver volume is lower side, and when 80% liver has been involved by the cancer, more than 5 lesions, and with combination of a chemotherapy. So these are the patients to be avoided. So in our patient, he is eligible as far as selection criteria is considered, and he is not having any contraindications. And we have also wider as far as our ILBS experience. You can see here 86 patients who has been received SBRT for the advanced SCC. You can see VP2, VP3, and VP4, and also inferior vena cava involvement also. So portal vein involvement or inferior vena cava involvement, single or multifocal lesions. Rather, multifocal lesion is around 72% our series, and this is relatively safe. And the response as far as progression-free survival at 6 months is 55%, 1 year progression survival is 35%, and 6 months overall survival is 88%, and 1 year overall survival is 50%. So with this, we thought of considering SBRT. Now, another interesting, whether this SBRT with immunocheckpoint inhibitors has a synergistic effect. This is an interesting study. It shows that this is step 1, the radiation-induced release of antigens, radiation-induced FPC presentations, and overall activation of the immune. This causes a immuno, you can say, restoration or immunoactivation because of radiation-induced injury, where the addition of immunocheckpoint inhibitors has a synergistic role. So with this, at this time of things, we have the baskets of therapies as far as considered the first line drug. Arterial was not available. We have nivolumab and we have lenvatinib. The patient is already on sorafenib, so hence we thought of nivolumab. And for nivolumab, there is existing literatures also for to support for this treatment. So what we consider from our ILBS experience of this nivolumab to be used for these tumors, particularly in this macrovascular invasion in 73 patients, we get a complete response in 1%. However, partial stable response has been seen in more than half of the patient. So this patient has received SBRT, then followed by nivolumab, and you can see the previous tumors are there, and it has nearly regressed. And this is the area of necrosis only represented by a fibrotic scar, and PET scan also suggestive of not having any significant disease activity. And in a long-term follow-up after 2 months, we have given him 2 sessions of tests in total, SBRT, followed by 12 cycles of nivolumab, and continued on lenvatinib. And this liver is relatively tumor-free. There is complete necrosis and complete loss of enhancement of the tumorous environment. So, in this patient, we have achieved so-called complete remission for around 2 years with therapies, and other therapies has been considered. So, can we consider this patient for the liver transplant? So, to consider a patient, as far as downstaging criteria is considered, patient has received the chunk of therapies baskets. He has been considered to be put off ICI to see the tumor biology and to consider liver transplant as curative therapy. And this is our subsequent speaker, the surgeon who is coming to, it is his series, where they have shown that live donor transplant can be considered even VP3 and VP4 patients when these patients has been downstage by giving the tear and followed by immunotherapy and has been considered for a stability of the periods. And the transplant disease-free survival is seen in 51%, and survival is overall is 48% at 5 years. So that is quite good as far as this disease progression is concerned. So with this, we consider this patient for the live donor transplant. And when he has been gone for the transplant, his AFP PCR normal, DNA was not detectable, and the transplant, after the transplant, the external liver shows the tumor has been completely necrosed. There is no large vascular invasion. It's very interesting to see that having an extensive portal vein thrombus who has responded well to the combination of therapies and there is no lymphovascular invasion, there is no peritoneal invasion. And this patient, after 6 months follow-up, is doing okay. His liver is still also tumor-free. So to summarize, my patient is a SLF total duration of disease around close to 12 years. His reactivation then remains the CLD, develops advanced ACC. He has received combination of TES, SBRT, tyrosine kinase inhibitors, immunocheckpoint inhibitors, then remain free of immunocheckpoint inhibitors for 6 months. Then he has underwent lymph node transplant, and now 9 months going the lane, he is having disease free. So with this, we suggested that from this patient, if a person of SCC with PBT, that is BCLC, is presenting to us, first we have to see that child score A, B, or C. In C, treatment is limited. In case of B, we have to see selectively if we can give therapy depending on the liver functions. If child A, we have to see for these patients, portal vein thrombus also can be resectable provided the limited tumor model is there. If it's not resectable, they need to go for radiation therapy with TES and BP4 also similar way. If it's distant meds, they can consider for systemic therapy along with the local therapy. And all these group of patients, irrespective of the disease, they need a systemic therapy, either tyrosine kinase inhibitors or immunocheckpoint inhibitors for this. So with this, I just close this case and I open this case for discussion among our panelists who are going to guide us on how to proceed in this case.
Thank you, Ashok, for your very interesting and difficult to treatment case presentation. His presentation is often for the questions or comments from the audience.
Maybe we hear from Dr. Omata. He is mute. Professor Omata, please.
Yes, hello, Shivasarin, Ashok, wonderful talk. Well, I'm actually thinking about how to make a new guidelines. So according to your suggestion, especially the indication about the PVTD cases, I think it's a very important information. So I may consult with you about the new guidelines. Thank you very much. 谢谢.
Professor Sheena, or maybe the Dr. Kim can invite coordinators and panelists.
Ashok, can you hear me?
Yes.
Okay.
Sure.
It is widely extensive infiltrative HCC with portal vein thrombosis, and you are using every treatment modality, TAC, SVRT, and nivolumab, and finally successful liver transplantation for 9 months. It is very exceptional case, I think. The response to each treatment modality is very good, which means the tumor biology is exceptionally good. And finally, the alpha beta protein is less than 10. It shows also support the tumor biology is very excellent and exceptional case. Can you apply this treatment modality to other cases, or in general, in general practice? Can you recommend it? And if you recommend it, what's the rationale and scientific background to recommend your treatment model, everything modality to that same case?
Yeah. So first of all is one, biologically non-aggressive nature, as you rightly said that AP are normal. Second, he's having the reserved liver synthetic function. Always, all throughout this 3 to 4 years of journey, he's remained child A. So because of these things, we have a courage to give application of all the modalities available. Then third, when we go for the test, as here our radiologist are there, he has 2 concerns, which has been addressed very well, that extensive atrioportal sampling. So if initially the test is not effective, we often combine TACE plus SBRT. So when you go for TACE and SBRT, the addition of either tyrosine kinase inhibitor or a immunocheckpoint inhibitor is now already existing in the guidelines. So I am worried about combination of both the things which may be difficult, but otherwise in this case, after TACE if it is not responding or TACE followed by SBRT we have offered, we can directly go for the immunocheckpoint inhibitors. So this is, can say that it can be in the guidelines. And then obviously when he gets downstage, and previously we have waited in this patient for 6 months, but now even after 45 days of being off treatment as per as immunocheckpoint inhibitors, they can be considered for the liver transplant. This can be for all cases.
Okay, thank you. We are planned to present the second presentation. We'll move on to the next speaker. The next speaker is Professor Amar Mukund, a professor of interventional radiology at ILBS. He is an expert in vascular and biliary intervention, and he is one of the founding members of Indian Society of Interventional Radiology. He will deliver a talk entitled Bridging and Downstaging Strategies Before Liver Transplantation for HCC, including DDLT and LDLT. Professor Mukund, please.
Thank you, Professor Kim. I think I'm audible and my slides are visible. So first of all, very good morning, good afternoon, and good evening as per the time for all our panelists and different viewers. So first, it is my, I would like to thank APASL for having me here. And today I'll be talking about different strategies, what we use as an interventional radiologist. Though I'll try to sum up what is not being done by us as well, including SBRT and immune checkpoint inhibitors and TKI, just briefly within a slide.
Dr. Amar, you are muted.
Okay, sorry. So I would like to thank the organizers and APASL for having me here, and thank you, Professor Kim, for the introduction. So I'll be starting my talk. So as we all know that liver transplant provides the best long-term survival for patients of cirrhosis having HCC. And as per the, we know that Milan criteria for liver transplant has been validated, and we know that overall the outcomes of patients undergoing liver transplantation within criteria is very, very good. But unfortunately, only minority of HCC patients are eligible for within Milan criteria and eligible for transplant therefore. So for selected patients, downstaging may be attempted to bring tumors within the Milan criteria using liver-directed therapies, and that is what I'll be talking about. The benefits of downstaging include decreasing tumor burden and allowing time to identify patients with less aggressive tumor biology. And options for conducting downstaging includes thermal ablation, chemoembolization, internal or external radiation, or combination of various therapies. And there is another term which we are talking is bridging. So bridging describes the treatment of accepted transplant candidates within Milan criteria while on waiting list. And during the waiting period of liver transplant, patients with HCC are at risk of list dropout due to tumor progression, though this particular statement holds true for a Western outlook where the patient is allocated an organ. However, if we see the Asian background, most of our patients and most of our successful programs are live donor related liver transplant. So this may not hold true. However, there are certain conditions like if a patient is not willing for transplant due to various reasons, which is better known to the patient. So these patients would like to be within the criteria of transplant and would like to bridge it by different therapies. So that's why we may require liver-directed therapies in some patients who may not have a live donor or who may not have adequate finances, or there are many other reasons for which they cannot undergo a transplant. So in any patients who require a waiting time of more than 6 months should be given a bridging therapy. So what are the therapies which are needed for downstaging and bridging, which includes the most common, the most simple is the thermal ablation. But thermal ablation is limited for 3 to 4 centimeter of lesions. So where can we use this kind of treatment modality? So it can be used for reducing the number of HCC in a small but multifocal HCC. Suppose the patient has 5 HCC. He is not within the Milan criteria, not even UCSF criteria. So in such a patient, we can do multiple ablation sessions where we can ablate 2 to 3 lesions in a single sessions, or even 4 lesions in a single session. The liver function and the size of the tumor permits, and maybe downstaged or bridged. Then next is TACE. So TACE can be done for larger lesions which are not amenable for thermal ablation, because thermal ablation is even as good as a curative therapy, and for any lesions about 2 centimeter, it is considered equivalent to a curative therapy. So TACE is a transarterial chemoembolization where we go into the liver and inject chemotherapeutic agent within the tumor and embolize the artery as well. So we put chemotherapy, induce ischemia, and try to reduce the size of the tumor by necrosis. It is mostly done for large and multifocal HCC. Then comes transarterial radioembolization, which is very similar to TACE, but instead of a chemotherapeutic agent, radionuclide is injected. Mostly yttrium is injected, yttrium-90, which is injected within the tumor, and it is a beta emitter, and it leads to reduction in the tumor over a period of 3 months. Then SBRT, we have already heard Dr. Ashok talking about SBRT in our previous talk. So SBRT is a stereotactic body radiotherapy, which is mostly being done in India is for HCC with portal vein tumoral thrombosis. However, it can be done for a large tumor as well, or it can be used very well in combination of the therapies. Now coming to combination of therapies. So the most common combination which is being used by interventional radiologists is transarterial chemoembolization with ablation, which may include RF ablation or a microwave ablation, which is used to achieve a complete response in tumors of up to 6 centimeter. Then we can combine chemoembolization with stereotactic body radiotherapy. It is mostly done for large HCC and HCC with PVTT, that is portal vein tumoral thrombus. Further, TARE can also be combined with SBRT, and which is very commonly being done at Medanta Institute. And our next speaker is a very eminent surgeon and one of the tallest figure in transplant in India. And we have a very good paper from Medanta talking about TARE and SBRT, which I'll be showing. And with above therapies, we may try and combine TKIs and ICI, or both, depending on the patient's, the institutional protocol, whether the patient's liver condition permits. Depending on various factors, it may be combined with oral and IV chemotherapies and immunotherapies. So coming to some of the cases, like how we do it. So ablation, first I'll show you one of the case. Here is a single HCC, which is about 3 centimeter. Patient got ready for a transplant because he came to know about that there is an option of transplant. He was not ready with donor and finances and other logistics. So we went ahead and did an ablation for it. This is a post-ablation CT image where we see a complete ablation. If you see this linear area, the black thing is the track through which the needle was entered, and we ablate the track also, so there is no needle track seeding. So a surgeon would be happy that while ablating, we have not actually done a tumor seeding in the track. And then this patient got a liver transplant a year later, and this is the liver transplant image for this patient. Then the other is combination therapy like TACE plus microwave. I'll be showing here. It is a multifocal HCCs. A patient has 4 HCCs for which chemoembolization and TACE has been done. You can see this image, TACE is being performed. You can see lipiodol deposition in various tumors around. And for all lesions which were amenable for needle placement, ablation was performed using microwave ablation. And you can see there is a complete response. So patient was downstaged within the Milan criteria and later got a liver transplant. TACE plus TKI, this is another interesting case. Here you can see a very big, a huge 17-centimeter tumor. The patient was given an option of liver transplant. It was not ready for it. And then we did a chemoembolization. So the first session of chemoembolization, this is after chemoembolization, because in such a huge tumor, we don't go and completely embolize. So this is very important. We all know that post-embolization syndrome is very high in patients whom TACE is done and they have a large tumor. So we generally try and reduce the vascularity and don't try to completely obliterate all the vessels supplying the tumor. So if you see the peripheral vascularity, which was seen previously, is not seen at the end, but we left all these arteries. So the treatment was well tolerated by the patient. And after 4 sessions of TACE, so again, we'll come back to the question which Dr. Ashok asked, like how many sessions of TACE can be done. So this is after 4 sessions of TACE and 1 year follow-up. So the patient underwent 4 sessions of TACE. This is what we see after a year follow-up. The lesion has reduced in size, no vascularity, and this is how it looks. And it was done using drug-eluting beads, so DEB-TACE. This is a 3-year follow-up. You can see how the lesion has further shrunk in size. This is 2017. So we started, so this is 2 years follow-up. So we started in 2015 and this is 2017. And this is 2019. So 4-year follow-up. So after 4 years, the patient every time refused transplants because of his own personal reason, but we had downstaged the patient. Thereafter, unfortunately, he got ready for a transplant in 2020, but he succumbed to Corona pandemic and couldn't get a transplant, but he was disease-free at 5 years as well. So I'll just quickly show you one of the papers which was published 2 years back about survival and outcomes of patients who received drug-eluting bead TACE having HCC more than 5 centimeter. And these are the patients what we included. So naturally, we included good patients who had a performance status of 0 to 1 and childhood class A to B7. This was the criteria which we used. And we excluded diffuse infiltrative HCC, PVTT, patients with PVTT, ascites. So all patients had a overall good liver functions who we assessed, and we assessed after the treatment using MRECIST criteria. And these were the outcome measures where objective response and CR were described as per the RECIST criteria. So this was the treatment on follow-up. We could get complete response. So that was only 5 patients, but partial response was seen in 13 patients and comprised to 44%. Stable disease was in another patients, and there were 7 patients who had progressive disease. So average number of sessions we did was around 3, and median overall survival was 26 months. And survival at 1 year was 92%, and overall survival at 2 years was 51. And the mean diameter of the tumor treated was 8 centimeter. This is the survival function as per the Kaplan-Meier score. And this is how our study compares with other similar studies which has been done with large tumors. And here we stand. So we had a good survival of 92.7% at 1 year, and at 2 years, 51.7, which is pretty much comparable. Not exactly similar, but yes, comparable to what has been shown by other operators. But these patients had overall a smaller tumor. We had this survival for a larger tumor. So we concluded with this study that TACE may be offered for patients with advanced HCC, and TACE has a good response. So I'll quickly show you some more cases, and then I'll show you some of the literature, what is available. So this is TACE followed by nivolumab. And as Dr. Ashok said, this was the era when we didn't have the current ICI and we were using nivolumab. So this is the same patient Dr. Ashok has said, shown you. So after, no, this is a different patient. So we see there is a big tumor, portal vein thrombosis. And here is after first session of TACE, because he had already had a CT from some other center. That's why I cannot show you the pre-procedure CT. This is the post-procedure CT, where we see a very huge diffuse HCC with PVTT, which is infiltrating going on the both side and involving the main portal vein as well. Then we did a second session of TACE. After second session, we see very big geographical areas of necrosis. And we see that the enhancement within the tumor thrombus has gone. So what we do, so our protocol is to inject cisplatin into some of the arteries if we see anything going towards the portal vein. So apart from doing TACE, we also inject cisplatin. And this is how we don't see any enhancement in the portal vein thereafter. Then the patient started receiving nivolumab thereafter, after second session of TACE. And this is the follow-up after 3 months. This is follow-up after after a year probably. And this is in 2022, that is almost 4 years. And this is just a few years back, he came to our center, that is 7th of July 23, and this is how it is looking. So completely treated, disease-free for 5 years. And he's again thinking whether he should get a transplant or not, because initially he was very much negatively counts that he cannot get a transplant with portal vein tumor thrombus. And now since he's leading a normal life, so now he's thinking whether he should get a transplant or not, although we are convincing that he should get a transplant. So next case is TACE plus SBRT. This is the same patient which Dr. Ashok has showed. This is arterioportal shunts, extensive. And this is what Dr. Ashok was telling. So what is important in this particular case, that the patient has portal hypertension and developing it very fast. So unless until we close these kind of shunts, he will develop ascites and decompensation. So this is very important to close these shunts, and these are so extensive that gel foam or coils are unable to do so. That's why we injected glue with lipiodol, and you can see it is going all through the portal vein. And this is how it looks thereafter. And then simultaneously he is getting SBRT and he is getting other TKIs as well, and he received nivolumab also. So this is the follow-up which we know and we have discussed in detail. So with this, I'll be talking about some of the literature, what is available. So majority, because if we talk about portal vein thrombosis, because that is the most important thing that makes a patient unresectable. So radioembolization or SBRT comes into play. So this is one of the article which was published in Hepatology from Riyad Saleem group, and this is a cohort of 207 patients with 15 years experience. And they said that those 207 patients, the 3 years, 5 years, and 10 years overall survival rates were 84%, 77%, and 60% at 10 years. So very fantastic, survivals. And 24 patients amongst those who were downstage, they developed recurrence with median recurrence-free survival of 120. And the most important thing was there was no difference in overall survival or recurrence-free survival for patients who were bridged or downstaged. So in this study, they showed that Y90 is an effective treatment for HCC in the setting of bridging or downstaging. So we all know and we agree with it that yes, TEER has a great role to play. Though in BCLC we don't find it in a prominent place, but yes, we feel that that's important. And this is again a very interesting paper from Medanta Medicity, and Professor Soen is already there, who will be speaking after me. And their experience in dealing LDLT patients having HCC with portal vein tumor thrombosis after downstaging. So they attempted a downstaging in 43 patients, and they were successful in 27 of 43 patients to downstage. And of 27, 25 underwent live donor liver transplant. The 1 and 5 year overall survival and recurrence-free survivals were 82%, 57%, and the recurrence-free survival was 77% and 51%, which was comparable to survival in another 382 HCC patients without PVTT who also underwent LDLT. So, if you use these downstaging therapies in a proper way, like they did ablative TACE or a ablative ablative tear and combined it with SBRT. So they used judiciously SBRT as well as ablative dose of radioembolization or transarterial chemoembolization and achieved a very good response. And this is a very commendable work which has been done by their institute. Then coming to another 10 years outcome of liver transplant and downstaging. In this paper, what we see that those patients who were within Milan criteria and were downstage, this is the Kaplan-Meier graph, whereas those who were downstage to within Milan criteria, this is the graph, which is very much comparable. But those who were beyond Milan criteria, they had a relatively poor prognosis as compared to it. So if we downstage to Milan criteria, definitely a patient have better survival if we don't downstage. So recurrence-free survival, similarly what we see. So if those who are not downstage will have a very early recurrence, if you see a very early recurrence, and overall, don't fare well in long-term follow-up. So in this paper, it was concluded that patients with HCC successfully downstage within Milan criteria, 10-year post-LT outcomes were excellent. However, tumor characteristics and lack of AFP response, so biomarkers are very important, before LT were associated with failure to achieve downstaging. So downstaging shouldn't be just looked for as an imaging thing, and biomarkers should always be looked whether the biomarkers are responding to the treatment or not. So another thing, poor tumor response to TACE before transplantation. Oh, okay, so this is another paper, I think, while making slide, I did some mistake. So in this paper, what they said that even if after TACE there is a poor treatment response before transplantation, that identifies patients at risk for post-transplant recurrence. So if after TACE there is no response or a poor response, those patients are not good for transplantation, even if it is downstage and marginally it comes into the Milan criteria. I'll explain it in another fashion, like if it is a 7-centimeter tumor and you are able to bring it to 5 centimeter, but you have done a full dose TACE. So that patient, and if you compare with another patient who also received a full dose TACE for a 7-centimeter lesion, one having a complete necrosis and one having only 30% necrosis. So one having 30% necrosis may not do as well as one having a 70% or 80% or 90% necrosis. So a response to a treatment actually determines the overall quality of the tumor. Those tumor who respond to treatments, they fare better. So this was this. So another interesting paper. So bridging and downstaging with TACE in early and intermediate stage HCC. This will answer again Dr. Ashok's question. So in this paper, they studied 324 patients, and out of them, 129 received LT, 32 of whom had responded favorably to TACE. So if they concluded that if LT is done in patients whom downstaging is achieved, then LT significantly, the overall outcome is improved. However, the LT rate significantly decreased if patient received more than 3 sessions of TACE. So any patient who is receiving more than 3 sessions of TACE. So what I tried to explain in my previous slide is a similar kind of thing. If anyone who needs more than 3 sessions of TACE may not be a very good transplant candidate. So they concluded that alternatives to liver transplant, such as novel systemic therapy, should be considered for patients who are beyond Milan criteria after 3 TACE procedures. So 3 TACE procedures may be considered as one of the important thing to be done if a patient does not respond well to 3 sessions of TACE, who is eligible for TACE should get alternative therapy because they may not do well even after a transplant. This is what this patient said. And just few words about immune checkpoint inhibitors. And in this patient, in this systemic review, they have said that immune checkpoint inhibitors are safe and effective in unresectable HCC, but a caution is warranted regarding their use in LT setting because of high graft rejection rate. But at the same time, we have another paper from Taiwan in which they analyzed pooled data of 22 patients, and they found that 42 days was a good time to wash out, good time and a washout period before LT for HCC for patients who have received immune checkpoint inhibitors using atezolizumab, nivolumab, or pembrolizumab. So this is what we know with the literature available, and I have shared my experience. So I'll conclude that current data suggests bridging and downstaging offers a better overall survival and recurrence-free survival. Poor response to LRT while bridging or downstaging is associated with high post-LT recurrence, and immune checkpoint inhibitors may be used with caution while being used in a pre-liver transplant setting. Thank you so much for your patient hearing.
Okay, thank you, Professor Mukund. Your very impressive performance and beautiful final results with the TAC and DEPTACE and others is very impressive. There are two questions from Professor Diana Payawar. One is, if the tumor is hypovascular, will TACE be still effective? And second question is, will the etiology of liver cancer be a factor in choosing the downstaging therapy?
So it's a very good question. So first of all, hypovascularity, how do we assess hypovascularity? That is important. So in all patients where we see a patient is having a hypovascular HCC based on imaging may not be good, because imaging depends on the time of injection. So many times what we call as an arterial phase may not be the arterial phase which is required. That's why there is a lot of standardization on imaging, and LIRADS is coming up. So even in hypovascular HCCs, when we do TACE, we find that there is definitely some vascularity. But having said that, if any lesion is up to 3 centimeter, ablation would be a better option as compared to. But yes, in cases of larger lesions, we can try TACE in case even on going in and doing a selective arteriogram, we don't find a vascularity, then TACE may not be as effective. But if you know beforehand that it is a hypovascular tumor, TARE may be a better therapy as compared to TACE in case ablation is not possible. And as far as etiology is concerned, it may be related to immune checkpoint inhibitors, but right now all kind of ablative therapies, including TACE and TARE and microwave and radio frequency ablation, the overall response to the treatment doesn't depend upon the etiology. However, recurrence may depend. So recurrence may happen, which may depend upon the etiology of HCC. However, the treatment response doesn't depend.
Okay, for downstaging and bridging therapy, the treatment modalities is very different, various treatment modality we can use as you show. And there are many different kind of combination. So my question is how you can determine what kind of treatment modality you first choose, and when you choose a combination, and how you can determine the sequence or the order of the combination therapy. It's very difficult questions.
Yeah, I know. So thank you so much for asking that question. So first of all, I'll just go back to the basic. So we all know that size is the most important criteria. So we all decide on size law. So what size? Big size tumors will get transarterial therapies, and a small size tumor will get ablative therapy. So there is no doubt about it. As far as large tumor and with portal vein tumoral thrombosis, again, that becomes again a difficult situation. And then we are stuck. So if we have a option of getting a TARE done, a large lesion with PVTT, I'll go by TARE. So transarterial radioembolization using yttrium-90 would be one of the better options. If not available, again, because data is coming up that SBRT and then followed by TACE is a better option. This is what the data says. Although in our institution, what we prefer is we do TACE first and then we send the patient for SBRT. So either can be done, although we haven't analyzed the data, and we are looking to the different literature coming from other parts of Asia. So we will try to look into it, which one fares better, whether SBRT followed by TACE or TACE followed by SBRT. Right now we are doing TACE followed by SBRT, but yeah, we can do in other way around, like SBRT followed by TACE. But large lesion with portal vein thrombosis, radiation has to be there in any form. It may be internal radiation through tear, or it may be external radiation through SBRT. So that is to be done. Another TKI and ICI has to be decided by the hepatologist, and depending upon the overall liver functions, the variceal status, and on the etiology, say like what the etiology is and what patient is able to tolerate, because tolerance is also important, side effects are important. So those are things to be decided by the hepatologist.
Okay, there are one more questions from the audience. Please give us a short answer. Is there any criteria to decide between two TACE sessions?
So as per the majority of the guidelines, we generally do a TACE after 1 month. So this is the majority of the guidelines, but there are certain places where they do it after 3 months, but majority of the guidelines says 1 month. So this is what we follow.
Okay, thank you, Professor Mukund, your beautiful presentation. We will move on to the next speaker, Professor Arvind Soin, a chief hepatobiliary and liver transplantation surgeon, and also served as a chairman department of liver transplant, HVP surgery, and regenerative medicine at Medanta, the Medicity, Gurugram, India. He established liver transplantation in India in 1998 and have credit of more than amazing 4,000 liver transplantation. He is an innovator of many transplantation skills. Also, he worked on liver transplant after the downstaging of HCC is highly appreciated internationally. Professor Soin, are you ready to present? He will deliver a talk entitled Criteria for Selecting HCC Patients for Upfront Liver Transplantation. How far to extend? Dr. Soin, please.
Thank you. Yeah, thank you very much, Professor Kim and Professor Sareen, Ashok, all my friends at the APASL Liver Cancer Group. I will start to share my screen now. Can you guys see it? Yes. Okay, so I've been asked to talk about upfront liver transplantation in patients with cirrhosis and HCC. And I'll deal with deceased donor and living donor liver transplantation slightly separately, because obviously considerations are slightly different. I have no conflicts of interest or disclosure. Now, I'm going to talk about upfront DDLT based on size and number, upfront DDLT based on size, number, and biology. Then I'm going to touch upon the concept of transplant benefit and how it bears on decision-making and selection and allocation. And then finally, going to talk about upfront LDLT, how it may be different from upfront DDLT for patients with cirrhosis and HCC. Now, first, upfront DDLT for cirrhosis HCC, when basically, you do upfront DDLT when you expect the 5-year overall survival to be in the Milan UCSF range, about 75 to 80% at 5 years, and you expect the recurrence rate to be less than 10%. At that time, you can think of upfront DDLT. Still, majority of the allocation systems in the world go by that. So we'll talk about the evidence for using size and number. Looking at the BCLC update of 2022, basically, here you have very early stage 0 and early stage A, where there are early stage 0 is small tumors, preserved liver function, good performance status, and early stage A is Milan, basically within Milan criteria, preserved liver function and good performance status. If they have cirrhosis and portal hypertension and or elevation of bilirubin, these guys will go to transplant. So that's the only really upfront group that the BCLC suggests. Moving on, we recently at the INASL, we had a consensus meeting on HCC and we proposed a modified BCLC staging system. And apart from the same categories of early stage 0 and stage A, where if they have portal hypertension and raised bilirubin, they would go to transplant. There was another group that was outlined for transplantation, and that is the patients who have tumors within criteria, but they have end-stage liver disease, and they are able to withstand a transplant. That means performance status 2 or less. They will go to transplantation. So this is clearly the unambiguous, incontrovertible groups of patients that can be taken to transplantation upfront. Then, of course, a little bit about why patients with less than 3 centimeter tumors should also ideally have transplantation. There are several papers that suggest that even for small tumors, while overall survival of resection and transplantation may be similar at 5 years, it starts to go apart at 10 years, and recurrence-free survival of transplanted patients is far better at 5 years and 10 years compared to resection. So that's why I think that if logistics and the circumstances permit, all patients with any HCC, which is within Milan or within UCSF, and the patients have cirrhosis, should ideally be allotted transplant organs or given a living donor liver transplant. Now, of course, we all know about Milan and UCSF. They basically give you results of approximately 75 to 80% 5-year survival. And everyone agrees that in the absence of macrovascular invasion and extrahepatic spread, these are standard indications based on size and number. But now, the big question is who follows conventional criteria? And actually, the answer is practically no one. And why is that? Because many things have changed. Everybody's understood the importance of tumor biology. Everybody is starting to give into and agree with the concept of transplant benefit, which basically means the benefit of transplantation, incremental benefit of survival with transplantation compared to the next best non-transplant option. Then, of course, living donor liver transplantation has come in and downstaging has come in. Now, so the original dogmas in selection of patients for liver transplant, patients who had HCC, were based on size and number, Milan and UCSF, and utility, which means how much they survive after transplantation, to now size, number, and tumor biology and transplant benefit. So how are the considerations different for DDLT and LDLT when you're selecting patients? Obviously, everyone wants good survival, so utility is important in both situations. Equity is important in DDLT because there is restricted, scarce number of deceased donor organs. In LDLT, double equipoise is important. That means you have to have maximal recipient survival and 0 donor mortality and minimum morbidity. And of course, the concept of transplant benefit should also ideally apply in both situations. So among the various criteria, there are conventional criteria, morphological, then there are biological criteria. And actually, practically every society follows biological criteria along with morphological criteria. And they are based on AFP, whether it's absolute value or delta rise or downstaging response, or PIVCA2 DCP, which is basically a surrogate marker for microvascular invasion, and PET FTG18 avidity, which is a bad prognostic sign, response to local regional therapy with downstaging, waiting period with or without downstaging, and then neutrophil lymphocyte ratio or platelet lymphocyte ratio, basically the inflammatory markers, histology, and biomarkers. So practically, like all of the societies everywhere in the world will agree that morphology and biology both are important. Now let's look at evidence for upfront DDLT for HCC cirrhosis in systems which consider size, number, and tumor biology. This concept of TRAIN, that means the waiting time, the radiological response to local regional treatment, alpha-fetoprotein, and inflammatory scores, acronymed TRAIN, published by John LaRute's group about 7 years ago. They saw that if they scored these patients with the TRAIN score, which included all these, they were actually able to transplant 37% additional patients compared to Milan with exactly the same intention to treat survival from when they actually got listed on the waiting list, with exactly very similar recurrence rates. So obviously just size and number alone is no longer the key. French score, we all know they consider tumor size, number of nodules, and alpha-fetoprotein. And as long as the alpha-fetoprotein score is 2 or less, the recurrence rates are very low, less than 10%, which is our standard for accepting upfront DDLT for HCC patients. And the 5-year survival is nearly 70%. So apart from the French criteria, unfortunately, in Europe, most of Europe, they will still only list within UCSF and within Milan patients. Another good score that came up 6-7 years ago was model score, which is a model to predict recurrence after liver transplantation, which is based on PIVCA2 and alpha-fetoprotein with a cutoff of 315. And they saw that if you use this score, and if the score was low, the model score was low, whether the patient had tumors beyond Milan or within Milan, they basically did extremely well in terms of recurrence rates, low recurrence rates. Now, looking at the Japanese multi-center study that propounded the 5-5-500 rule, which means the largest tumor size up to 5 centimeter, the number up to 5, and AFP less than 500, they saw that if they compared Milan criteria with the 5-5-500 rule, the 5-year recurrence, the 5-year recurrence-free survival, and the 5-year overall survival were very similar. And if you put together both the systems, then what you did was you actually gained transplant for 14% of the patients without any compromise in recurrence rates and survival rates. So again, this is like expanded criteria for LDLT, but this could easily be used in DDLT because you're getting the same survival as the Milan and UCSF DDLT systems. Now, also Kyoto criteria, again, they had tumor number up to 10, tumor size maximum up to 5, DCP less than 400. And if they met these criteria, then the recurrence rates were less than 5% at 5 years. And DCP, as we all know, basically a surrogate marker for microvascular invasion. What about the Asan medical criteria? I am quoting some LDLT criteria, but I'm only looking at those which are giving us survivals less than survivals equal to Milan and UCSF at 5 years and recurrence rates less than 10%. So AMC originally published this like over 15 years ago, 200 plus patients. They said that the tumor size less than 5 5 or less, lesions 6 or less in number without any macrovascular or extrahepatic invasion. They basically found that those which were within Milan did as well as within ASAN. This is within ASAN, this is within Milan, and the recurrence rates are well in the 10% range. And similarly, the overall survivals at 5 years were similar with Milan, UCSF, and AMC criteria. But of course, with AMC, they were able to transplant 10% more patients than Milan and 5.5% more patients than UCSF. Our own data, which we published a couple of years ago, basically suggested at that time, we considered patients until the end of 2017, and we had done about 2,350 transplants, out of which we analyzed 405 patients with cirrhosis and HCC without PVTT. Currently, of course, this number has gone to about 4,100 liver transplants and 700 plus patients of HCC we've transplanted. So in this cohort, which we published a couple of years ago, we had about 50-50 Milan and outside, and about 60-40 within UCSF and outside. And we found that basically the overall and recurrence-free survivals at 5 and 10 years were pretty impressive with this all-comers criteria. We basically accepted any size, any number, without extrahepatic spread and without macrovascular invasion. And we had a 5-year survival of 64% overall and 10 years at 55, and recurrence-free survival that 5 years and 10 years was 70 and 67%. We identified 3 risk factors: alpha fetoprotein more than 100, UCSF outside of UCSF, and FDG avidity positive. So these were the 3 risk factors. And we found that if our patients had no risk factor or one risk factor, that's the low risk group, their recurrence rates were just under 10%, 9%, and their 5-year survival were at 73 and 89%. And this was again very similar to UCSF and within Milan. So we would suggest that all comers, as long as they don't have FDG avidity and their AFP is low, can actually benefit with the same to the same extent with a DDLT as patients who have who are strictly within Milan and UCSF. So our low risk group has a very low recurrence rate of less than 10%. However, the moderate risk and the high risk groups do have high recurrence rates, 25% and 46%. And currently we would engage in downstaging for the high risk group. Moderate risk we would still accept for LDLT, and low risk we would accept for DDLT. Now let's understand the concept of transplant benefit for a minute. You know, when UNOS had these MELD exception points for HCC up until 2012 and then slightly modified up to 2015, what they were doing was they were giving extra points for very small tumors, and they were transplanting a lot of patients with early HCC, and they found that the survival benefit of liver transplant over resection at 3 years was only 0.7 years, and at 5 years was 2.8 years in nearly 9,000 patients over these 8 years from 2002 to 2010. And you know, that was not such a good deal because that deprived a lot of non-HCC patients of good livers, whereas the early HCC ones could actually have resection. So that's when they modified their criteria to include biology. Now let's look at how transplant benefit actually works in DDLT. If you look at this 40-year-old gentleman with hepatitis B, with Child's B, who has 2 HCC nodules, 6 and 4 centimeter, they would be outside Milan and UCSF. But the gain in life expectancy over TACE is like 8 years. It's a huge gain. Whereas this early tumor, 65-year-old gentleman, child's A, HCV, 4 centimeters, single lesion within Milan UCSF, the gain over resection is only 4 years at 10 years. So obviously, the more advanced tumors actually have a higher gain in life expectancy or transplant benefit. And that's something we have to recognize. Now let's look at the LDLT situation. This patient with a 4.5 centimeter tumor, child's A, the expected 3, 5, and 10-year post-transplant survival will be 85, 80, and 75%. Post-resection, 3 and 5-year and 10-year, 85, 50, and 20%. So at 5 years, there is not much benefit in transplanting such a patient, but at 10 years, the transplant benefit becomes pretty clear, 75 and 20. But look at this patient with advanced beyond UCSF tumor or HCC, 8 centimeters, 7 tumors, no PVTT, 3 and 5-year post-transplant survival, 75 and 65, no transplant, only 10 and 0. So obviously there's a huge transplant benefit here. And that's why such patients should have a LDLT. And we, again, looked at our own data, the published data, and compared this with historical benefit of ablation and found that in the low-risk group, the transplant benefit at 3 years and 5 years was 27 and 42 months. And in the high-risk group, even the high-risk group, there was a transplant benefit of 17 and 25 months with transplantation. So transplant benefit, I think, is ready for prime time. It should be included in DDLT selection criteria. So patients with possibly extended size and number, especially number, with low AFP and DCP should actually be considered for DDLT listing. Is that happening anywhere? Not really, not except maybe the French AFP score. I mean, I'll briefly take you through this UK allocation system. Now, this is for general non-HC and HC transplant patients. The UK DDLT allocation system for the last 5 years is based on transplant benefit, which is an artificial intelligence algorithm, which is made on 21 odd factors. So how does that differ from the previous model? And I'll tell you the relevance of this in HCC. Initially, they used to look at need. That means liver was offered to a patient who had the shortest predicted survival time without a transplant. Or utility. That means who had the highest survival after transplant. Now it's all about benefit. That means liver is offered to a patient who's predicted to gain the most benefit compared to treatments without transplant. So this area of benefit given by the transplant to that particular patient is what the UK allocation system currently has. But unfortunately, what happens with HCC is they're still listing only basically within Milan patients. So they are looking at tumor alpha-fetoprotein, maximum size and numbers, but the starting point, the cohort, the denominator is all still within Milan. And if only they could include outside Milan patients with low AFP, we would actually know if the transplant benefit score for these so-called advanced HCC patients would be justifying allocation of deceased donor organs. This is an example of the transplant benefit score in the UK system for a PBC patient. And when you put in all the values for the factors, you basically get a transplant benefit score, and whoever has the highest transplant benefit score is the person that the organ gets allocated to. Now, what about living donor liver transplantation? Upfront LDLT for HCC, these are the considerations. You have to look at transplant benefit. You have to make sure there is double equipoise. That means recipient and the donor has to be safe and the recipient should benefit maximally. But the other thing is that a long wait is usually logistically quite difficult in the LDLT setting. A lot of people travel long distances from home, so they can't keep going up and down. Some of them during the waiting period will progress. And then one can argue if transplanted them, they would have lasted much longer. They would have lived much longer. So long waits are difficult in LDLT. Now let's look at what the ILTS recommended. I led this consensus group. We gave our guidelines about 3 years ago from the ILTS group. And basically, although we did not reach a consensus regarding expanded criteria, but we all recognize that tumor biology, including response to neoadjuvant treatment or downstaging treatment, was very, very important. So we concluded at that time that DDLT should be offered to those within Milan or UCSF, and those who are outside should be downsstaged. Tumor biology was not incorporated that time because of the opinion of the majority of the people there. In living donor liver transplantation, it was recognized that LT criteria can be different from deceased donors. They must include biology, alpha-fetoprotein, DCP, FDG avidity, and response to local regional therapy. And they should not have macrovascular invasion or extrahepatic spread. And one should aim for a recipient survival at 5 years of more than 60% and zero donor mortality. So these were this is a summary of the guidelines that we put forward from ILTS at that time. And if you go by this rule, that the criteria can be different from DDLT, then all these came in, and I'm just going to summarize the various expanded criteria in LDLT for HCC. The Tokyo 5-5 rules, 5 nodule, 5 centimeter. The Kyoto criteria, 10 nodules, 5 centimeter, DCP less than 400. I've already alluded to this. They all gave excellent overall survivals and very low recurrence rates of 6%, 10%, and so on. Asan Medical, I've already discussed the AMC criteria, Kyushu criteria, any number of tumors less than 5 centimeter, DCP less than 300. Again, excellent survival overall and recurrence free. Turkey, any size, any number, no extrahepatic spread, macrovascular invasion. They achieved overall survivals of 57%. And Toronto, any size, any number, no macrovascular invasion, good histology or moderately good histology, overall survival 70%, and recurrence free 72 and 77 at 5 years. Our criteria I've already discussed and given you the results. So this is the other point that I wanted to make about our own criteria. The moderate risk group, where the risk of recurrence is about 25% or less, still has an excellent overall survival at 71% at 5 years. And we would accept such patients upfront for LDLT. However, the high risk group, we would downstage. So to summarize, ladies and gentlemen, for DDLT, size, which is up to 6.5 centimeter, number from 3 to 10, low AFP, low DCP, these patients can be considered for upfront DDLT. Others should obviously be downstaged to within criteria. We should consider transplant benefit in DDLT allocation systems. For LDLT, extended criteria could go up to any size, any number, as long as the AFP and DCP are low and FDG is non-avid. And this would definitely give a patient survival overall of more than 60% at 5 years. And as long as you can do your donors safely, this is justified for sure. Those outside of these criteria should be downstaged. Now, transplant benefit should obviously be factored in for LDLT and not just for LDLT, even for DDLT, but especially for LDLT because there's no competition for the donor. And we've seen that the more advanced HCC patients will actually have more transplant benefit over 3 to 5 years than early HCC patients. Thank you very much for your attention.
Okay, thank you, Professor Soin. You clearly summarized the utilization of biological parameters adding to conventional morphologic parameters in LDLT and DDLT separately. Thank you all of the audience really enjoy your excellent lecture.
Thank you.
Dr. Soin's lecture is open for questions or comments. One question from the audience is the long-term prognosis favorable and many benefits for liver transplantation for HCC? with or without portal vein tumor thrombosis, even after downstaging, after chemotherapy, other interventions?
So although today I did not discuss downstaging of patients with PVTT, but I'm happy to take the question because our paper was quoted a couple of times, and yes. So what happens is that we have realized that the reason that we accept patients with portal vein tumor thrombosis for downstaging and transplantation protocols are basically 4 reasons. One is that all PVTT does not mean systemic spread. 2, there is evidence that, which is non-transplant evidence, that all kinds of radiotherapy, SPRT, TARE, EVRT, they can result in disappearance of tumor in the veins. So there is a thing like treating the tumor in the veins. 3rd, we have shown that there can be long-term survival of such patients who are downstage with radiotherapy and then transplanted, right? So these are the main reasons why we believe in this philosophy, right? Now, who are the patients who should be taken for this kind of treatment? I mean, VP4 patients do a little worse than the rest. Very high alpha fetoprotein, more than 10,000, or if the final AFP is higher than 2,000, we've shown that in our paper, they do badly. But people who are good prognosis patients, who've been downstaged and then transplanted, many of them have long-term survival. Actually, we have now 15 plus patients out of the 50 odd that we have done who've had more than 5 years survival, who are living for 8, 9, 10 years.
Okay, as you commented, for portal vein tumor thrombosis, in the area of living donor LT is much more prevalent, such as in Asia, India, Korea, and Japan. Many hepatologists and transplant surgeons will agree to your opinion. But how about the European and United States transplant surgeons' opinion? How is different from Asian?
Prof. Kim, the problem is that the European opinions are tainted by the fact that they do mainly deceased donor transplantation. So they're always thinking of equity in allocation. They're thinking that this guy after transplant, he's got HCC PVTT downstage. He may live for 3, 4 years, 5 years, but the other guy might live 20 years. So that is the problem. So, there is a equity and a justice issue in their mind because they're doing DDLT. But human beings are the same everywhere. I mean, if I was a European and I had HCC PVTT, I would be equally dying to live longer than an Asian patient compared to an Asian patient. So I would love to have a living donor transplant option. In fact, I have to tell you, we have transplanted many Caucasian patients that way. So they have come to us for downstaging of their PVTT and then have LDLTs because they know that they can't have it there.
Okay, thank you. Another question from the audience is, what's the chances of a recurrence after DDLT versus LDLT?
It's been shown in several studies that the recurrence and survival are very similar with LDLT and DDLT. That's all.
Okay, thank you. Because of time constraint, I would like to close this session by thanking all 3 speakers and participants. Thank you.
Thank you very much. Good to be with you all. Bye.
Professor Umata, please.
Thank you. Wonderful. See you soon. Yes, great.
Bye-bye.
Right. Ashok, great. Right. Yeah, Shiv-Sarin, bye-bye. Yes. Good night.
Thank you at the end. So
everybody. Dogumeji, how are you?
Hi. Thank you very much, all the speakers
Yes.
and also moderators. Thank you very much.
Yokosuka sensei, look sleepy.
okay, thank you. Bye.